All right, so we'll go ahead and get started with the cases. We'll just kind of run through as many as we can get through comfortably. But they're just different scenarios that would kind of, there may be more than one right way to approach them. Like I said, a lot of this is up to clinician judgment. And so feel free to share. There may not be a right answer, and you can make your case. Okay, so the first case is a 23-year-old Marine Corporal who was sent to you by PCM as persistent mood symptoms. That criteria for major depression. Been doing psychotherapy. You're seeing it for the first time, talking about pharmacotherapy, and together you decide to start an SSRI. No specific concerns about his job and going to do his job. He's at work doing okay. So, do you have the flow chart next? Yeah. So if you go to this, we're kind of open up to thoughts about where we are in this flow chart. Or,
I think you're receiving a question about what but I would talk with this point and I would think interesting. Less I can start about the performance. That you need collateral that doesn't sound like you need it necessarily.
Yeah. Dr. Amin mentioned that before, that uncomplicated initial pharmacotherapy may not require anything. I think that's reasonable. I know that there were some people that I worked with who would do light duty kits for the initiation of any psychotropic medication for a period of time, just to prevent something that initial period from going on an IA or TDY or an exercise before we had an idea of was that condition stable. But I think that personally, I kind of err on the side of what Clark alluded to. I think it can be more harmful because sometimes people will go high and right. If command gets wind duty restrictions, you put somebody on a firearms restriction, and oh my God, can we let them be alone in a room by themselves for more than 20 minutes? And so it's a balance question. Again, it comes back down to your judgment. So in this case, if we went with Clark's perspective on that algorithm, we probably would say full duty. Answer to question number one, they're in full duty status. I think at most you would do here to say they're going to have a minor condition that might require a period of weapons restriction, something along those lines, via a light duty paper chip with no information, just recommendation for weapons hold until dose is stabilized for a period of time. That would be the maximum that I think is reasonable. Landon, do you want to do your next one?
Yep. And then before I think that's fine.
Yeah.
Before I go into the next one, there's actually a question/case in the chat. So we're going to improvise and address this case first, and then I'll ask you all about the next case. So actually, we're going to click back up to here and you'll give no spoilers. So someone in the chat was asking, they noted they're an Air Force provider at a base where sometimes they're the provider. This could be you, okay? This could be your next conversation. I appreciate it. All right, so, and they're saying, hey, I see U.S. Army, U.S. Navy, U.S. Coast Guard. Should I be initiating medical processes? Their current strategy has been to ask the service members who their command contact info is so they can contact command directly, provide profiling details. But the question is, should they be initiating profiles and then later med boards, regardless of their duty station? So my initial answer, and I'm going to turn it over to you as well. My initial answer was thoughts of if you're the primary provider and they're stationed at your duty station and you're continuing to see the service member for some period of time, then yes, potentially obtaining profile access is quick and easy. You can do the trainings. I have Army and Navy access ready to go. Admittedly, I have an Air Force office locally that makes it really easy if I needed to do a profile. I can just email my officer and they have access to ASIN. So I have ways to continue to provide care, at least for profiles. For medical board for later, depends on to what degree I'm going to continue to provide care to that service. What are your initial thoughts?
Yeah, so I have Air Force, Army, and Navy access, and I was doing a rotation and I had a patient from the Coast Guard that needed a board, and I was like, I forgot about the Coast Guard. I had everything else ready to go. And so I engaged with the medical officer, which I think in general is a good idea. And a lot of the units around here don't have medical officers, which is kind of frustrating. But like a lot of the things that we take on ourselves to engage with command about, I would bring the medical officer for a unit. I mean, that was my job for 2 years, was to the inpatient unit, the unit would call me and give me an update. There was no command call. And I would provide the command the update. Now around here, we don't have that luxury all the time because there's not a medical officer in every unit. But I would engage with the medical officer for a unit, like the operational provider, if you're the mental health provider, to get assistance with that kind of thing. And that's what I did with the Coast Guard, was I called the Coast Guard GMO, and I said, how do we do this? And they walked me through the process.
Okay. All right, who here feels confident in deciding whether or not someone needs an ad set for a med board in the US Army? Yeah, awesome. Thank you so much for volunteering. Can I have you read this next case, Jeff?
Yeah. So the case 2, case 24-year-old active 24-year-old active duty U.S. Army, 11B infantry without prior past psychiatric history comes in for voluntary evaluation of insomnia. You conduct your assessment and provide the diagnosis bipolar unspecified. History notable for being an excellent soldier for command, running 10 miles 3 times a week prior to morning PT, like Rosina does. Increased need for sleep compared to years. Recently won Best Warrior competition at his base and occasionally uses alcohol to help crash and fall asleep. Further evaluation of possible underlying alcohol use disorder is needed. That's
You're a amazing professional. If the service member has reached MRDP, what are your recommendations?
They have a diagnosis, David diagnosis now of bipolar unspecified. So in my understanding of the algorithms we went over, yes, it's reaching.
Okay, so you're making the argument bipolar unspecified. We look at the chart and the chart says psychotic or bipolar disorder. So I guess I'm going to ask the audience, is bipolar unspecified included or not? Do they need mania? Do they need bipolar? What do you got? Let's say that again for the virtual audience. The argument was bipolar unspecified is not a great diagnosis. And I agree, but for some reason I got this wrong in reviewing, and that's why I brought it up as my first case. Because I was missing. Any other thoughts? Is it med boardable? Should you be initiating the process? Documentation after I was told I was wrong, and I found some details that look like this, some summaries and other details, and it does explicitly list in this enclosure 2 from an old memorandum that's now technically out of date, bipolar disorder unspecified, 90-day temporary profile, reassessed at 90 days to determine if permanent profile is formed. But I think it's the general rule of thumb. Whereas 90 days unspecified is. Oh, sorry.
Where is this located?
This is an enclosure 2 from a headquarters department of the Army memorandum from a couple of years ago. This is expired in 2019.
Yeah, this is, so a lot of people might not know this, and they may say that bipolar 2 should be out. That's what I should get. So you will encounter resistance.
So this is why knowing local, culture is important. But clinically, you really want this person deploying where he might be sleep deprived, right? So again, it becomes our ethical and moral duty now to protect this individual, right? Could you imagine if he gets full-blown mania? And our diagnoses, again, these are not diseases, these are disorders, right? So I've had a lot of discussion, and ultimately, if you are hovering around bipolar disorder, MEB, and the patient, there's a lot of due process within this process. So let's say they disagree, they can appeal it and re-appeal it, and let the MEB, PEP folks decide whether he should return to PEP or not. But I cannot think of any situation where I would say he's okay to be sleep deprived for a couple of weeks because the operational tempo is high and we need to do that.
So as a follow-on to that, are we saying that this person is then like definitively at the MRPP, or they still need more accessible for reading?
Yeah, I mean, we know from the way the illness behaves that this is lifelong, right? There's waxing and waning, there's a seasonal component to it. Patients worsen in the summer, think of their symptoms going up, sleep deprivation worsens that. So pretty much a lot of the things that we do to people, if we deploy them, tend to be things that can precipitate or perpetuate hypomania or mania. And then obviously you could have psychosis with it. And that's just not, and then the other thing is, it's not like we put them in the trash can, diagnostic basket, and somehow he's gonna say, I'm gonna remain milder than bipolar 2 or bipolar 1. And if you look at bipolar 1 and 2, their dysfunction is actually with bipolar 2 might be worse. Because there's probably we're throwing people with comorbid personalities. So prognostically, it's not any better to have like a milder form of bipolar disease.
Even though the standards that were updated like this year, as of June 6th, they include only like bipolar 1 as definitively being a disqualifying diagnosis for other bipolar spectrum, including choose and climate, substance medication use can be considered on a case by case basis. Depending on like duty modifications and how much.
Yeah, I mean, I just try to make a case for you that you should refer them. And then let's say they're like a lawyer or physician where the Army has spent millions of dollars. That they might say, we're gonna keep you in a cocoon and you are going to do your job. So they might be retained, but push that decision process to the big machine rather than you deciding should I or should I not. And even if the patient disagrees with you, let them know that, hey, you're gonna be able to deal with the process.
That's a really important, wow, I would echo a lot of that. So like, what I told people when I refer them to a PEB is I'm not saying you have to leave the military. Like, I'm not making that decision. I'm asking somebody else to weigh in on, as a panel, like, what do you think is the most appropriate next step? And so, not that we're punting it, but punting it a little bit to, a big committee to say, like, hey, this is what we think based on what we've heard from the treating doctor, I think is usually the right answer.
They're more like guidelines anyway. There you go.
This is the 26-year-old second class that you're treating, has been doing really well. Started on a medication, no specific concerns except when she came to see you for follow-up. She's having some intermittent, mild worsening of her anxiety. You decided you're going to go a little bit up on the medication dosage. What do you guys think? If anything. Go to the next slide. Oh, if we could do it a second.
And these were also posted in the chat as well as the group.
Oh, nice. Can you, do I have one more slide after this?
Yes.
So just to give her a second. So what do you guys think? We made a medication dosage adjustment. How does that factor into it?
I think the condition is still relatively minor and expected to stabilize with dose adjustments and medication optimization. So I think at most a light duty kit or just remain their current status. I think if I have any concerns or anxiety about their ability to do the job, I might let the fan know about this, but probably not if it was really minor and this patient then bothered it.
Yeah, I agree. So I think what the point here is that there are no occupational impairments, right? So the point that I want to make here in the next slide, then, if you look at the DoD clinical practice guidelines for the climate limiting conditions. I did not have like I hope it was, but
Yeah.
it talks about stability a lot. And that the CPGs that people shouldn't be deployed if there are not 90 days of stability on psychotropic medication and with regard to the mental health test. But that word stability is never really defined completely that I could find. And so I think it leaves some interpretation. And so is going up on a dosage of a medication a little bit to address a little bit of worsening of anxiety. Is that unstable? Probably not. So when you read these things, I would keep coming back to the idea that clinical judgment is still paramount. And even the instructions say that. And so read them, interpret them, but interpret them with the knowledge and the framework that you have from.
I think it's hard years back with kind of how removed we are from the units and not really having like communication with units and like pretty frequent communication with commanders. But in theory, like when we leave here, you should have a sense of what the option is. So that may also like sway your decision. Like if she's about to like start ramping up in trainings or deployments or things like that, maybe you do put something more official in as opposed to like, no, we're hanging out, we're just doing our day to day.
That's a great point. Yeah, I totally agree. And if you go to an operational building, like the Oscar psychiatrists would come to our meetings at our unit meeting and sit in and have an idea of what was going on, kind of culturally and operationally. And then they can wait. And so you don't always have that luxury, kind of like around here, we don't always have that, and maybe short staffed. That didn't happen until I was about a year. And so you kind of adjust fire as you need to, but I think that is kind of the point, that you can use your judgment, you can use your understanding of what's going on to apply the instructions in the most productive way.
You might find in the volunteer to answer this next one, and I'll read it.
All right, you want to read it?
Would you mind? All right, so he's gonna find a volunteer to answer the following question, but I'll go ahead and read the prompt. So we got a 32-year-old active duty U.S. Navy submariner, currently on recruiting duty, presents to adult outpatient behavioral health with depressed mood, initially receives a diagnosis of adjustment disorder, specifically related to transition from recruiting. Excellent brain, loves submariner, hates recruiter. However, after removal from recruiting duty stressor, return to job, the trial of therapy, it becomes clear he actually has an underlying major depressive disorder. Has this service member reached MRDP, and what are your command recommendations about his return to his unit, his job, and systems to continue? And what else would you like to know?
What was the previous job?
Submariner MLS, flying jobs, doing stuff out there, recruiting.
We have clearance.
So the initial question, have they already reached MRDP in your opinion?
I'm gonna go with no.
Okay. Why or why not?
Although he had the diagnosis of adjustment disorder, removal of the stressor, like got rid of it, I think.
Did not, sorry, just to clarify, went back to the job and was still depressed.
Oh,
Like,
still
was depressed.
Well, I'm sorry. I consider read the full prompt, but I mean, has he been started on medication?
So that was what I was expecting when I said the why not, is what's his trial of treatment, right? So where would you say you're at in this diagram? You would say med portable or not, MDD?
I need a telescope. The chart for cancer.
It's measurable.
I apologize if you can't see it. I did also put it in WhatsApp if you prefer. I apologize for putting you on the spot. Anyone else help them out? Though? Because MDD is med portable. You were arguing already as he had a trial. So what would, in your clinical judgment, what would any of you say is an adequate trial of treatment for MDD?
More than one visit.
More than one visit, excellent. What else?
Medication is a trial.
And why do you ask how many medications? How many do you think is adequate? Prior to considering that. I like the idea to try one, but more try seven. Does it have to change classes in your clinical judgment? Okay. Maybe not. Any other multimodal therapies required? If they are willing to take meds but never made therapy, is that okay? These are all super thought, because in the end of it all, it's provider judgment, right? Have they trained, and you were right, that's where we're at, is he needs a trial treatment for the NDE, and may, on the future, ongoing medical, depending on.
What if, like, for this scenario with MDD, what if the patient doesn't want to take meds and it's just on prescribed therapy and it's not working, like, would two modalities be like, you know, outpatient as well as like IOP, would that count?
Yes.
So you don't have to be like, care, table.
Any disagreement or concerns, if they refuse to consent to certain modalities, any reason why they have to?
Now, there could be a scenario where the patient completely refuses, treatment recommendation. And you just document that, and then there's not much you can do, but you just refer them. What usually happens is that ends up impacting the ratings and all that. If it shows that, they have this dysfunction, due to impairment, due to limitations, but they have declined recommended therapy or non-adherent, whatever, that kind of thing. It might be able to be shot.
It's easy and able to.
No, we don't use CMJ people, we don't force treatment on people, but people who make those decisions, but they can't be in the hurry. If they're not allowing the system to help them to get better.
In the management, that's actually a criteria for MDD referral is not willing to go through with recommended treatment. That might be able to avoid a medical board if they otherwise did, and they go on limiting for a period.
Okay, you want one?
Yeah. So we have a 19-year-old private first class Marine man is worried about him because he's spending a lot of time alone, kind of new to the fleet, not really doing so well. He had a little episode where he broke down abruptly after a relatively minor correction in his military bearing. Came to see you, had diagnosed an adjustment disorder, went to the MFLAC, which is the Marine Family Life Counselor, and MCCS, Marine Corps Community Services, they don't like the counseling program. Comes back to follow up, and he's still not doing well. Feels like the Marine Corps is not for him. So what are we thinking about next steps right now?
You've been in,
Sorry?
how long have you been in?
Let's say that he's been in the fleet for like 7 months. Does he want to stay? Reluctantly, he says he does not. He thinks that the Marine Corps is the source of most of his frustration.
Doing his job?
Is he doing his job? He is meeting minimum standards.
How would that be?
I'm sorry.
How would that be? There's other.
Oh, that's. Yeah, I mean, that is in my opinion, the right answer. Once that adjustment disorder is on that list of the man-made conditions that are not appropriate for referral, acute adjustment disorder. And in this case, that's going to be the quickest way out. The way that I look at that is that that's part of his treatment plan, is that the thing that he's having difficulty adjusting to is the source of his pathology. And therefore the treatment is to remove that thing. And that can be done most expeditiously through a condition not amounting to a disability administrative separation. I'll talk about those a little bit more the next time.
Yeah, this is why I use the allergy or anaphylaxis analogy. Right? It's like, well, would you rather give someone Benadryl or you just remove the source of their allergy? And it's better for them in the long run. Better for both the service and the individual. They can move on with their life.
Absolutely. I totally agree. Most people want, if they're coming to you at this point, they want to pursue that. You will generally get requests for that more than you will get protests. Yeah.
But if he went in the service for less than 6 months, would he be able to get a failure to adapt?
I never did any of those. I've heard about them. I never actually experienced doing one myself, so I don't know the answer to that.
The process of, traditionally, it takes a lot less time
Mhm.
than an asset, especially in that.
I don't know the details of that, so I don't want to speak on that.
So I can comment on that. So most legal, yeah, they're not a big fan of anything legal. If you have an administrative, because the burden of legal requirements is much higher. Even if you know someone falsified their information and trying to get them out on, whatever the legal, lingo is, it takes a lot of effort. The easiest thing is if they got computer judgment disorder, you make sure that, so the biggest mistake is the command is not tracking. And then there's no, you gotta have the legal paperwork showing that the command attempted to rehabilitate. It could mean counseling, it could mean referral to behavioral health, it could mean, sending them to financial counseling, whatever that may be. But you gotta show that you have made efforts to try to improve this individual's life. And if you don't have that, the clock is ticking, right? It's 6 months. And before you know it, you might end up in the medical board realm, and now the individual is stuck in the army for 13, 14 months, until the board event, event.
How long would you wait, I guess, how long would you wait to accept this particular person in this kind of case? Would you see them twice, 3 times, 1 time?
So I'll give you a meter. They get 2 to 3 months from the minute they're diagnosed. Now, sometimes you get individuals who start having issues before they show up. So they start having a lot of issues in their AIT or their MOS school. And then for us, in the Army, the clock starts there. So they might be like month 4 into their thing. And you gotta quickly move on that. And that's a way we advocate for that individual soldier. In the Navy, there's like, you gotta be able to show that you're good for 48 hours or something like that, and then does anyone know? And then, the clock goes to 0 for adjustment disorder.
Sorry, 48 hours.
Yeah, so let's say I show up and I start having issues, I meet my chief, because I have developmental trauma and authority figures, I can't stand them.
Mm-hmm.
But then there's a few days of the period when I'm feeling good, and that goes away. All of a sudden, that adjustment disorder has resolved, and then when he has another issue, you start having acute adjustment number 2, and I believe it's 48 hours actually. But we will get back to you on that question. But pretty sure it's 48 hours.
I have not heard that, so I'll find, I'll think I can
Does
find it.
anyone in the virtual form know? 48 hours, pretty sure.
I think it is, and I think you can say, like, when they left the Friday from work, they were having a problem, and they were fine over the weekend, and they showed up, and they clock reset.
Yeah, so the clock resets in the Navy, but in the Army, you don't have that, so you gotta move on it.
Right, here's next.
It's a bit of a long case, so I'll read it out loud for the non-interested. I'm gonna try to get multiple opinions on this one, I want to debate through her. 36-year-old active duty U.S. Army combat medic, comes in, he's a 68 whiskey, he likes whiskey. He comes in for MDD, undergoing treatment. His Prozac was increased 3 months ago. He's been going to therapy for 9 months, and then he gets a DUI. So you're during your trial of treatment for different diagnoses, it's a DUI. He's enrolled in a substance use disorder treatment program, and currently at residential. When the command contacts you, the embedded behavioral health officer who was treating this service member before his substance use, and they want to know what should happen. You get some collateral, and they tell you that he's got poor work performance, it's beating bad over the last several years. They don't think it's related to his 3 prior deployments to Afghanistan. This is in combination with now apparent substance use disorder, and the commander is very interested in assisting the service member in leaving the Army as soon as possible. Well, I want to open it up to y'all though. What are your thoughts? There's a lot of different things going on. The commander wants them to leave as soon as possible. They're at a residential treatment. Go ahead.
Yeah, I think you gotta be concerned about PTSD, which doesn't sound like it's been evaluated or properly screened for. And so, yeah, we talked about how you can add and set people with substance use disorders, but if this is like a comorbid with PTSD kind of picture, which would be kind of classic. You don't want to miss that, that would be, unfair to go to action separate if it was a PTSD court.
Also, what's the time of service? Can you repeat that for people? I mean,
Actually, I'm gonna walk around with Mike too, and then I'll also repeat it virtually. The first concern was, what if there's underlying PTSD? Further assessment may be required in addition to further treatment. Even though the service member may be looking at an ad set related to substance use disorder, there are other things on the chart. Then we had a follow-up question of what's the time in service? For some reason we include it, let's say it's 15 some odd years.
Getting out of it's about 8 years time of service, what the PTSD or with deployment and it's automatic NPD. Dr. Ferguson.
So one of the things you're talking about was concern that perhaps there's a PTSD exemption. And really that's what you're concerned with as well, is what if there is an underlying case, he then shouldn't be ad set because of PTSD. There's also another diagnosis on the chart that he currently has that you're treating for. Can you ad set for substance use disorder while currently undergoing trial treatment for MDD? What are your thoughts?
DUI pose a failure to treatment, like is he gonna be?
The DUI will start the substance. What are you saying that failure is in treatment?
Of the, if this happened while he was in residential somehow, or?
No, this is the trigger for the substance use disorder scan.
If the DUI resulted in some kind of criminal injury or significant property damage, and a like judicial proceeding were ongoing that was separated from military judicially, would that override any due process that you would have? I would think yes.
They both go up and one starts from which one fits together. It's not
Cool.
yeah. So they can both go simultaneously and MEB can go up at the same time as stuff is going up. And then it goes to the flag officer and the flag officer says yes or no to whichever path they decide.
So recall earlier the burden of proof, the goal to prove that they do not have a med-mortable symptom. So looking at the chart here, dysfunction due to a non-med-mortable, you're considering ad set in the middle panel right there along the center, right? You're also considering, actually the fourth one, substance use disorder. Let's say he doesn't go for an ad set for substance use disorder, even if it's treatment failure, or other administrative separation related to the DUI, other things deemed low. In that screener, up above that was the medically mortable condition. They do have a medically mortable condition. They have MDD currently ongoing treatment, undergoing his trial of treatment. They are not an MRDP. So this is one of those clinical judgment logistics with the command, talking about the realities of what this looks like. And then as was mentioned by Dr. Youngman, but I don't know when I said it. Yeah. This was mentioned before. At that point, we have a catch-all where it goes to flag officer. So someone with a star goes through and reviews it and clarifies and double checks in order to add that somebody for say misconduct or something else while the current med works. That's not necessarily where this case would go. Just depends on how you relationship with your command team, you're able to talk to them and figure out the best common ground for your service members.
I would say this is also a really good case that you have an MDB office that you're planning to do a relationship with, like reach out to them and just be like, hey, this is kind of where I'm at. Like, what do you think? Like, use the resources you have.
Just to caveat with the virtual world, it was an argument that this might be a good case to contact the MEB office or the PEDLO, talk to the people at the office and say, hey, here's where we're at, what do you recommend?
So this one, we have a 27-year-old first class who comes to you after discharging from an inpatient unit. She was admitted after she had heard the voice of God telling her to go save her mother from an abusive relationship. Subsequently was diagnosed with schizophrenia on the inpatient unit, stabilized, and then you met her as part of your participation in an IOP program. What do we think? Easy, right?
The only consideration for this is that if she's in IOP, sometimes it makes it challenging to get her to her VA appointment that she'll have to eventually do, so coordinating with the IOP programs is important.
You mean the VA appointments as part of the network?
Yeah.
Yeah. All right, that one was a straightforward one, and yeah.
The only other thing to review on that last case was the concerns that was brought up. Obviously, I was later gonna have a case that is PTSD underlying and intermission, not just a reminder, PTSD something what we're talking about a few slides ago. Otherwise, thank you very much for your participation. We'll actually skip some of these other cases. The slide decks will be available in case you want to work through them on your own and assess your judgment. Additionally, regulations and references included. But we'll open it up for questions.
Yeah, so any questions for these guys? Yes.
I just want to say, sir, that, you're right about the 48 hours per day, finding us this sort of, I found that over time.
48 hours? All right, cool guy. Excellent. All right. So real quick, the question about dual track is what they're referring to. So someone may qualify to be entered into medical board, but they may also be for chapter 14 for us in the Army. They may have done some sort of, some sort of misconduct for which they need to be punished essentially. I'll give you an example. An individual P7 history of PTSD is positive for heroin. So that's a dual track consideration. And in my prior job as a division psychiatrist, in our chain, our first flag officer was a 2-star, not a 1-star, but it needs to be a general officer. And so one of my jobs was to give him an opinion on which way this should go. And I'll do it in a memo, the lawyer, make the lawyer happy. But the bottom line is there's no guidance on what principles we use. I'll tell you what I came up with working with our forensics program director at the time. So I looked at 3 things. Whatever condition they had, did it impact their decisional capacity, right? And we'll go into that. Those we know what those are. Did they, were they in a situation that we consider reckless? So recklessness is capacity to foresee outcome plus decisional capacity. So did their condition cause them to not be able to see? So the only thing I can really think of is if you're delirious or severely psychotic, for example. Now, in terms of substance-related states of any sorts, you can't, it just, our court system or legal system doesn't allow you to say, oh yeah, I, misbehaved because I was drunk. But it's all, because we look at prior to intoxication, what kind of state of mind you were in. And at that point, you were being reckless by, and then the other piece is responsibility for knowledge of wrongfulness, capacity to appreciate the criminality of conduct and volition to conform. The volition to conform, those of you that might end up in forensics, they used to use that in the 80s. But I found it to be a helpful guide. So it's the idea that, let's say you've got severe claustrophobia, someone tells you, get inside that tunnel, and you say, no, Sergeant, I can't do it. Like, don't get inside that tunnel. No, I'm not doing it. You could argue that that person's anxiety impacted their volition to conform to what's expected of a soldier. Does that make sense? So 10 years from now, when you're out there and you're trying to write that memo, email me and I'll send you the stuff. Any other questions or comments? So I would say every year we've been doing this. What I've seen in these outcome measures is our efficacy has declined in terms of people's confidence level. Any idea why? You are more knowledgeable before you end up sitting in this. So I think it goes to show that our curriculum is working in terms of hitting this on a quarterly basis for the virtual world. In 3 months, we're going to have AdSep. We're going to hit that, and there's a lot of nuances, the administrative separation. But I would say this is probably one of the best NEB lectures that I have sat in. Very organized.
I think one, so I put this up there, if you look at the map, this is literally a screenshot of the text being about graph stuff. And I think that the screenshot intentionally, it's gonna be so like sharp and controversial. If you look at the map, it says what the Marines always say. The Marines always say is lethal Trump better. That's the mandate, but I would say that this is geared toward things like spray and ankle. And if you have somebody who pop positive for marijuana, it helps have spray and ankle. More likely than not, the legal avenues like supersede medical. When you get into things like the psychiatric condition impact, behavioral things, that's legal consequences, that gets much more. And so we interpret some of this stuff with that. And engage, superior, surgery, things that help with this. And second point, really quick, Alan brought up 12 months of any restrictions in a career in the industry. So that wasn't clear. Every time I said 12 months on the portion that I made, that means total 12 months in retirement.
Is that per condition or anything?
Last I heard, that is anything. So they are saying that you are not in full duty status and full life employment for 12 months, you're automatically